We are meeting under very different circumstances this year. We would normally have been meeting out with our Monash partners. Unfortunately, we are having to run our annual forums through the Zoom platform. Before we start, I would like to acknowledge the traditional owners of the lands in which you are all meeting, pay respects to elders past, present and emerging. I don't think any one of us could have imagined the year that we've had in 2020, this time last year. It has required an enormous amount of work in managing the COVID-19 pandemic. And I just want to thank all the people that have joined us. All our clinicians and staff have been working incredibly hard over the past 9 months now during the pandemic. It has required us to think differently about how we deliver cancer care. It has been incredibly challenging for our clinicians and team members to be able to think of different ways in which we can ensure that we provide high quality care to our cancer patients. And how incredibly challenging it has been for our patients, for our patients' families. It has been so difficult to ensure that we can provide that comprehensive patient-centred care. And I've been amazed by the work that our teams have done during, the work that our teams have been able to do during this time. For our Smics team, they've been working remotely for all this time. And trying to continue to provide that support to our colleagues who have been working in the hospital. We've had to change direction, we've had to change a lot of our thinking for this year to ensure that we could adapt to the COVID-19 environment, and the teams have done a remarkable job. COVID has also provided us with opportunities to partner with our colleagues across the state, and there's been some tremendous work done with our Victorian Comprehensive Cancer Centre partners, our other Smics partners and the MPCCC partnership to ensure that we are collectively working together to provide the best quality care and sharing our innovations and our learnings during the pandemic environment. I would like to thank all the Smics team, all the staff, all our consumers, and thank you all for continuing to support Smics and all the work that they've been doing over the past 12 months. Even though we're not together, I'm sure the Smics team are going to be very happy to present to you some of the experiences that our consumers, our patients and our clinicians have had over the past 12 months. So thanks again for your support. I look forward to hearing from our presenters.
Welcome. Thanks for joining the Smics online forum. My name's David Moyle and I'm delighted to host you for the next hour. On today's program,
your mum is fighting for her life alone. Heartbreaking.
What do you call a dying patient? You know, is that somebody that's only got hours left to live, or is it somebody that's got 5 days?
And in cancer care, if you disrupt that process, it really adds to the grief.
COVID-19 has changed our lives irrevocably. Globally, tens of thousands of people have lost their lives and many more have found their way into hospital. Here in Victoria, we have endured months of restrictions, with many cooped up in their homes and their apartments, unable to see family and friends. And this inability to connect with our loved ones has perhaps been one of the toughest challenges so far. We all know of incredibly sad circumstances where people have been unable to attend funerals or be at the bedside of someone in their final hours. But it's not just patients and families who are distressed by these situations. Enforcing strict visitor restrictions may cause healthcare staff significant moral and psychological distress. We know that visitors can contribute to the emotional and the social well-being of the patient, and denying access to partners, family members and friends can cause ethical conflict for the staff providing the care. We'll talk to two nurses currently caring for people affected by cancer and hear their experiences during the past few months. We'll also take a deep dive into the issue of moral distress, as we expect that Victoria's healthcare workers are likely to encounter moral distress, anxiety and regret arising from ethical challenges in cancer care. Balancing competing values in unprecedented, ethically complex situations is stressful because there's not a clear roadmap to guide those decisions, and there may not be one clear ethical response. So what does the next few months hold for cancer services across the state? The Victorian Cancer Registry's pathology notifications for cancer shows an overall reduction of approximately 30% in reporting. It's anticipated that this will have significant impact for individuals presenting with later stage disease and for the capacity of the healthcare system. But cancer won't wait. We'll talk with Dr. Andrew Hayden and Associate Professor Ziwan Wong, Joint Clinical Directors at the Southern Melbourne Integrated Cancer Service, about the future and what they perceive to be the key challenges ahead. But let's go back to understanding more about the impact of visitor restriction policies which healthcare institutions have implemented around the world in order to reduce the transmission of COVID-19. We're here in the family room of the oncology unit with Tracy, whose mum has been on her cancer journey for some time now, and Jessie, who is the Interim Director of Clinical Operations Cancer Services. Tracy, your mum Kay was first diagnosed with leukaemia back in 2014.
We got a phone call on Christmas Eve 2014, which was very interesting. Mum had been unwell for a little while. She'd probably had a cold, sort of flu-y thing from about Cup Day and was just quite tired. So I was having some tests and regular bloods, and then her bloods sort of were moving in a way that they weren't happy with, so referred her on to a haematologist who just wanted to do a bone marrow biopsy. Didn't think for a second that it was going to be leukemia, was quite sure that it probably wouldn't be, and then we got the call to say that she had acute myeloid leukemia. Basically said she needed immediate treatment and probably 3 to 6 months to live if she didn't have any treatment, so it wasn't a good prognosis.
I understand that your mum started treatment and responded well.
Yeah, so she went in on the 30th of December, I think it was, and we got told that it would be a trial. So yeah, so she started on a new world first trial, first recipient, which was a mix of chemo and a trial drug.
But things changed for Kay earlier this year, didn't they?
She had just short of, I think it was like a couple of weeks short of 5 years, but then she became unwell again, so she got an infection and ended up back in hospital. So.
And by then, were the hospital visitor restrictions in place?
Not initially. I think COVID was ramping up, but we could still visit. I think it was certain times, but I'm pretty sure it was certain time frames, but not complete lockdown and no visitation. So, thank God.
What happened after that, Tracy?
She became very unwell. It was just a constant battle of just trying to fix one thing and then something else would go wrong. And in that point in time, I think, is when the hard lockdown came, and then we couldn't visit at all. So that was really, really hard, and just trying to get information and finding out what was going on. Horrendous, absolutely horrendous. Knowing that your mum is fighting for her life alone, heartbreaking.
And I understand, Tracy, that your trip to take your mum back to the emergency department didn't quite go as you'd expected.
Yeah, so she became unwell quite rapidly. My dad's sort of getting very used to the signs of her declining and called me, and I came over, called her consultant who said get her into ED. So we popped her in the car, took her into ED, and then the nurse came out and sort of said, okay, we're right to go. I was trying to grab all her belongings and everything. The nurse wheeled her off, and we realised that we hadn't even said goodbye. I love you, don't know when we're going to see you again. And I sort of turned to Dad and just said, that was horrible, we couldn't say goodbye. We now can't see her, we don't know what's going to happen. Terrible.
Jessie, I'd like to bring you in here. We can all appreciate just how distressing that would have been for Tracy, to be denied access to someone and then suddenly realise that you may never see them again and you don't get the chance to say goodbye. It would be really devastating. I don't know how I would have coped in that situation myself. You spend many hours at the bedside of your patients during a shift, and sometimes that's for many weeks on end. I'd imagine that you develop a very special relationship with your patients, and you'd also get to know their families quite well. How difficult was it for you to suddenly have to enforce visitor restrictions?
Yeah, it was really challenging. I think throughout the year to my partner, I said, you know, I've been in this role for 5 years and this has been the most challenging thing that I have had to go through as a nurse manager. You know, it was really hard because you can empathise with every single patient and empathise why they need their family here. It's such an important part of the patient journey. You know, in an oncology ward, we have got people that are getting curative treatment, we've got people that are terminal, and we've got, you know, patients that are end of life. And so you have to factor in every single patient on the ward when you're making a decision about whether, you know, a visitor can come in. And while, you know, the organisation had as clear as guidelines as they possibly could, and we tried to be as consistent as we possibly could, every single patient and scenario needed sort of, you know, its own thought process and, you know, a different decision. And I would, you know, I'd go into my office and try and get some downtime, and the phone would ring and I would just dread it and pause because I knew it was going to be a family member ringing and telling me why they were the one that needed to come into the hospital. And, you know, I pretty much agreed with them every time. You know, if you have a terminal patient who's not end of life and they're next to a cancer patient who's having curative treatment and they don't have an immune system, bringing someone in from the community, especially in the height of lockdown, it was really risky. And you had to really balance, you know, what was the most appropriate decision to make. And it was, you know, it was really difficult, it was really emotional.
How did having to make those decisions affect you? And do you have to distance yourself in some manner so that you can make those tough decisions?
It was emotionally exhausting, and, you know, everything that came with the COVID restriction was extra work. So on top of trying to make all these really moral distressing decisions, you had to do your normal workload. And, you know, distancing yourself from patients, especially in oncology, it's just, you know, it's not something that's easy to do, especially if I wanted to make, you know, a decision based on the ward as a whole and a patient in particular. I really needed to know everything I could about them and the patient next to them. And so, you know, it's very, very hard not to get emotionally involved. And I think as well, when you're on the phone having a conversation with a family member, or you're down at the front door trying to console a family member that's trying to come into the ward and they're not being allowed in, if you know little intimate details about the patient, you know that what they had for breakfast, or you know they weren't feeling quite right, or they just told you about their gorgeous grandson that was born, it's much easier for the family member to feel like their loved one is being taken care of if you know everything that you can about them.
At the height of these outbreaks here in Melbourne, when you went home at night after a day on the ward, how did that compare to going home at night 12 months ago?
I guess I underestimated how important my social supports were. You know, how important it is to be able to go to my family and say, oh, you know, this was an awful day, or, you know, that glass of wine on a Sunday afternoon with your mum. So, you know, that was really challenging, that I didn't have those supports readily available. I was, you know, like I said, emotionally exhausted. I think I would go home and feel like a bit of a zombie and not really want to do anything at all. Like, I managed to have something to eat and then sit in front of the couch and, you know, fall asleep quite early. It was, you know, it was really challenging there, and I think, you know, my partner learnt to say, not, oh, was it a good day today? How was it today? And I remember sort of at breaking point, I said to him, I don't understand how my position description changed from the nurse manager of a wonderful oncology ward where we include as many family members as we can to a you know, a jail warden. That's what it felt like for some of it. And like it was just challenging, because you knew why you were enforcing the restrictions, and you knew that for a lot of patients it was really, really important. But then for other patients, you know, COVID was the least of their worries, and having family in would have made a huge difference to their journey.
Thank you, and I really want to thank all the nursing staff too, because they've been phenomenal, not only being nurses but social workers and taking part from the family side. They have my utmost respect.
What Tracy and many like her have experienced is incredibly difficult, and we all feel for people in this situation. Our rational selves understand the reasons for the visitor restriction policies. They're put in place to protect the patients, the staff, and of course the wider community. But we're dealing with emotions, with fears, with loss and grief, and often in these situations our rational thinking goes out the window. I spoke with Professor Claire Delaney to understand this better. Professor Delaney, clearly there are ethical considerations involved in restricting visitors. If our visitors are denied access to the patients in the hospital, who fills these gaps? And even if we rationalise the need for visitor restrictions, why does it remain so challenging?
It is challenging, and you're right to say that on a rational level, restricting visitors during COVID-19 is an important response. And so that rationally we can see that it would help with stopping infection coming into the hospital. It would help with visitors coming in and taking infection out of the hospital. And it keeps health staff safe. So lots of really good reasons, and it makes it a classic ethical dilemma, because on the one hand there are important reasons to stop visitors, but as you said, there are huge impacts, and most of them are felt, first of all, emotionally by patients and staff. So what seems like a rational decision is emotionally experienced. And I think it's really important to acknowledge that it is really hard, that, as you said, visitors do perform a really important function, and if they're not there, the people that must fill that gap are the clinicians. They're all the people that are left.
But Professor Delaney, what are the harms to patients that need to be considered?
Well, an obvious harm for patients is that when they're in hospital, they'll be isolated and separated from the supports that sustain them, their family, their loved ones. And that may have a flow-on effect that even prevents them from wanting to come into hospital in the first place, which might have been an unintended consequence of visitor restrictions.
But it's not just the patients who suffer. What impacts occur to the visitors, the families and the friends?
Yes, I think those relationship bonds are stretched when people are in hospital, or automatically you feel concern and anxiety about your loved one. Being able to go and see them, reassure yourself that they're okay, give them something of yourself, is so important in the process of supporting someone along a journey. And in cancer care, if you disrupt that process, it really adds to the grief. It adds to the complicated nature of dealing with a loved one being ill, and it can really reinforce that anxiety about illness. So lots of harms, I think, to visitors as well. They're connected to the patient, so you're breaking that connection.
Professor Delaney, you've just spoken about the isolation effects on patients and their visitors and families and friends. Would you talk a little more, please, about the gap that's there and how patients can be supported?
Well, the way patients are being supported without visitors coming in to see them is via the health professionals themselves. So they've been required to step up and address the lack of visitors supporting patients, and this has been it's not different to their role. Their role is to care in a really holistic way to patients. That's what health professionals do, and especially in cancer care. But To step up and do more of that work takes them away from other aspects of their work, but also it has meant that they have been witnessing despair and distress and angst of people that normally they can address, or normally they don't have to even address because the visitor and the loved one is there with them. So it's a big ask on clinicians to take this on. So it's extra work, it requires more resources, it requires them to think creatively about how to manage and care for each individual patient, you know, whether to use the iPad, the telephone, whether to contact visitors or family on their behalf. And so lots and lots more thinking, and it's also distressing when they're not able to address it.
Gail, you look after some pretty sick people here in the palliative care unit. How has COVID-19 made your job so much harder?
Well, 2020 has definitely been an interesting year. Probably one of the hardest years with COVID-19 that I've ever experienced in my career. As part of the palliative care service here at the Alfred, we deal with really, really sick and unwell patients in extreme circumstances a lot. But this really has been something totally different for us. And for all of my colleagues as well. I don't think that any of us have ever lived through an experience where we've not been able to have visitors in to see terminally ill patients, or even for that matter, in to see any patient in the hospital at all.
We spoke to Jessie earlier and she was saying the same thing.
Very unusual. Like, the hospitals have been so quiet.
Were there any allowances or special considerations given to visitors for patients who were dying?
There's a couple of things that we've done as a unit, and I know that other units around the state have done the same thing. We've been able to provide families with letters to enable them to come into the hospital, to be able to get through the roadblocks if they need to. There's also been, the government has said that, there's special consideration for people who are dying. But that also has created confusion at times because, those rules have changed, as we all know, as things have gone along. And, what do you call a dying patient? Is that somebody that's only got hours left to live, or is it somebody that's got 5 days? And there's been a lot of confusion around that, and it's been difficult.
Earlier in the year, Gail, when you could visit a patient, we've heard stories of huge queues outside the front door of hospitals, people waiting to get in, blocking the entry, waiting for the screening process. By the time they got to the ward, many of them were angry. Have you experienced that anger yourself?
Definitely. Myself and pretty much every bedside nurse in the state, probably. Families have been arriving at the hospital thinking that they can come and visit, as they would have done previously, and that isn't the case. They're firstly met with the temperature screening station, and they probably at that point also are asked, who they're coming to visit, why they're coming, because some of them potentially will be people that are coming in to go to an outpatient clinic, although they were scaled down. And then their next point of call is the security station, and while the security guys are there to protect us and they're doing a great job at that, sometimes the communication does not get through from the ward to the security desk of which patients are allowed to have families visit. And so, that causes angst for everybody. And I pretty much can say that nearly every nurse in the hospital at some point has had to go down and rescue a visitor from the security station and bring them up to the wards. I think the other thing that has caused angst here also is that very early on in the piece, we didn't necessarily have COVID-specific wards. And as we went along this journey, the wards would change on almost a daily basis. And, we have had wards here, as every other hospital has, that are specifically a COVID ward, no visitors allowed at all. So families will arrive, that ward may have changed, and things have happened really quickly, so it's made it very difficult for everybody.
How do you help your colleagues deal with that distress, Gail?
We've spent a lot of time talking to people. I think, they see palliative care walk into the ward, and I guess they know that they've got a soft shoulder or an ear, and so we have spent a lot of time listening to nurses, debriefing about what they've just been through, the difficulties that they're having, the anger that they're being presented with from families, and we know that they don't mean it. It's just, it is what it is, but we've run debriefing sessions. Nurses have experienced things that they've never experienced before, and it's hard.
Gail, during the past few months we've seen a rise in the use of telehealth and technology generally. Has this assisted in your process of dealing between staff and patients?
So there's a whole new world in the health industry nowadays called telehealth, and although telehealth has been around for a long time, we've found new ways of using it. If I use a patient who is in isolation, we have a laptop in their room. They're able to talk to us through that laptop, and we will be outside talking to them from a distance. And, we've used telehealth, we've used Zoom, we've used whatever means we've had to use along the way. This actually has also enabled patients to see their families. But it's not perfect. As you would know, it's not like sitting down in a chair next to a patient to have a chat to them about how they're feeling and what's going on. Everything's a little bit more stifled via the telehealth platform. And, it is very difficult to accurately assess a patient on the computer. But, yep, it's a means to an end and it's worked.
Yes, moral distress refers to a feeling that you're being asked to do something which you think is the wrong thing to do. And in the healthcare setting, it refers to health professionals being asked to go against their foundational, really strongly held value of providing care for a patient. And the distress comes when the decision is taken out of their hands and they don't have control over that action. And visitor restrictions is a really good example of it, because there's regulations and guidelines from public health point of view that it's safer not to have visitors in hospitals, and yet the clinicians can see the harm and the burdens that this is creating, but they're sort of powerless to do much about it, and they have to witness it but without being able to change it in some circumstances. So that's a really classic form of moral distress, having to do something required by somebody else that you believe is the wrong thing for the person. It's about distress about a patient.
We heard from Gail that they've taken steps to try and change and improve things. What more can we do to support our health workers who are experiencing this moral distress?
I think there's quite a lot you can do with about the experience of moral distress. The first thing I should say is a positive one, that the fact of clinicians feeling moral distress represents the fact that they care for another person. If you don't care much about something or someone, you don't get that distressed. So I think it should be seen as a really sort of positive aspect of clinical care, that this level of distress is there. And but I think it's also important that there are strategies to deal with it, because if you day after day in your workplace feel distressed, feel like what you're doing is not the right thing to do, it starts to build up, and that sense of that tension, that dissonance about what's right, what's wrong, and what you're required to do. So acknowledging that feeling is step one, and then giving clinicians an opportunity to really think through the moral aspect of the moral distress so that they can process their feelings. It might not take them away, but it enables them to understand the wrongness and whether or not it really is the wrong thing that they're doing or just the least bad option of a bunch of bad options. And that can be very powerful at resolving that tension and sustaining them to keep going.
Could the moral distress and anxiety result in longer term effects or even injury?
So moral distress starts as a feeling, an emotion, but if those feelings and emotions just build up, then of course that can affect your health. It can affect your motivation to be the best that you can. And as I said before, it can lead to burnout where you just don't have the energy to keep going in your role. So COVID-19 has been exhausting for clinicians, and the next phase of COVID-19, we hope it doesn't move to a third wave of infection, but the need for patients to be seen, and that what's often termed as a cancer surge, where people who've been holding back will all start coming in, and I think that's begun, means clinicians need a whole lot of energy all over again. So it is important to recognise the effects of moral distress that they've been through and that they're probably likely to face again with this surge of patients all requiring their care.
Professor Delaney raised important points about the future. We spoke with Associate Professor Ziwan Wong and Dr. Andrew Hayden about what they see as the key challenges ahead. Associate Professor Wong, now that we're getting past the second stage of COVID in Victoria, from your perspective as an oncologist, what are the foreseeable challenges?
So David, there are a couple. I think during the initial months of lockdown, a lot of people are worried about going to see their doctors, and suddenly a lot of people are not turning up for screening programs like screening mammography and other tests or seeing their specialists in the hospital for fear of contracting COVID. As a result, what we're seeing, possibly thousands of patients who are not diagnosed or undiagnosed at the moment, and we do expect to see in the coming months, maybe 6 to 12 months, what has been called the cancer surge, and we might see the health services inundated perhaps with large numbers of patients being diagnosed in the coming months who may have more advanced presentations, who may have more complicated clinical course, and potentially their management could be more difficult or challenging, and possibly with a less favourable outcome than if they had presented earlier. So I guess that's the main challenge that we will see, and this is across different tumour streams, commonly in breast, in lung, in colorectal, prostate, and also what we're seeing in head and neck cancers as well. This is quite well evidenced from the cancer registry notification in Victoria, where over the last few months there's been a significant drop of up to about 30% or so of patients not having been diagnosed with cancer when we would normally see.
Specifically from a medical oncology point of view, my concern is that not only will there be a potential surge in cases, but we will also see stage migration, where patients will be more likely to be presenting with later stage cancers. And as a general rule, later stage cancers require more chemotherapy, immunotherapy, systemic therapies. Early stage cancers are generally dealt with by surgery or radiotherapy alone, whereas later stage cancers are going to require either adjuvant or palliative systemic therapies. And so this stage migration together with cancer surge could be potentially a very large increase in the workload of medical oncologists.
And what type of supports are going to be important for our clinicians working into the future?
Well, I think there needs to be a clear recognition from organisations and administration that this is a potential problem that's coming, and we certainly need their support. Now, whether that means we're going to need increase in staffing, again across medical oncology, nursing, allied health, etc., chemotherapy suites, all of those things are going to be really stretched. And so I think there is also a potential concern regarding burnout and mental stress that clinicians are going to face. Heaven forbid we have both a cancer surge and a third wave, and if that happens at the same time with potential furloughing or patients actually being quarantined because of COVID, we may well in fact end up being in a situation where we can't treat everybody, and we are going to have to make difficult decisions about who can receive treatment and who will have to miss out. And whether that means not giving as much palliative chemotherapy treatments or not being able to treat these patients, those kind of things are going to certainly lead to psychological stress or distress for clinicians. And so, there is going to need to be supports for that kind of problem. And I think that, that also needs organisational support, and it needs we need systems or programs set up where we are proactive with regards to reaching out to the clinicians, checking how they're going, rather than waiting for self-referral, because the culture in medicine is not really one for putting your hand up and saying, I'm struggling. And I think we need to be actually reaching out to clinicians and probably, allowing them to debrief clinician to clinician rather than, waiting for them to get into strife and then needing to go and have, formal psychiatric help.
What does the next few months hold for cancer services across the state?
I think importantly to my mind is the awareness of the challenges that we will be presented with post-COVID. The new normal, so to speak, whereby there are differences in the way we manage and look after our patients currently until we have a vaccine for COVID-19 potentially. So there will be differences in the way patients are being seen at the hospital, as we are already doing now a mixture of face-to-face presentations as well as via telehealth, either video or phone. And some of the patients hopefully will come forward, if they do have concerning symptoms for cancer, to have their tests, to be seen by their GPs, hopefully be referred for specialist evaluation. I think at a higher level, what's also really important is for government and health service leadership to be aware of the incoming cancer surge in terms of a high volume of patients potentially with more complicated clinical situations who need to be managed. Certainly looking at what the preparedness of the health service for this surge is important, and looking at benchmarking across various health services as to what we're able to provide. And I guess some of the worry at the back of our mind is, will there be a third wave?
Professor Delaney, you've spoken about the need to acknowledge the effect of moral distress on our clinicians, and we've heard from Associate Professor Wong and Dr. Hayden about the challenges that are coming. How can we keep sustaining our clinicians for these future challenges?
Yes, I think the key word there is sustaining, how to sustain clinicians, because they are our frontline workers. They're the ones we need in this situation. And the other message that came through from Ziwan and Andrew was the fact that cancer won't wait. It hasn't waited. Patients are arriving now with more complicated cancers because the screening hasn't been done or the early diagnosis hasn't been done. So the pressure on resources is there, the pressure on clinicians is there. and is not going to go away. The other aspect of the future climate is that there'll be still situations where there's moral distress, because clinicians will have to prioritise patients where resources aren't enough to meet their needs. Small, sometimes bigger than small, decisions about prioritising patients will need to be made. And those decisions weigh heavily on clinicians. It can cause moral distress. It can also bring about moral anxiety, just worry that they might have to make these decisions in the future, even if they're not having to at the moment. So all of those worries, and as I've said earlier, are exhausting. They're emotionally taxing. They prevent clinicians from thinking clearly, doing what they do really well, is caring for their patients, bringing in the best evidence to do what their individual patients need, and the worry that clinicians feel for patients can really disrupt how well they can care for patients. So back to sustaining them. How can we sustain clinicians when their task is so hard? I think first, in really practical terms, we can normalise moral distress and moral anxiety. It's part of the job. It's part of the job, especially in a pandemic. And so that means making time and space for clinicians to debrief with each other, to have resources in place that support clinicians to do that, be that clinical ethics support to help them make sense of the moral issues that they're encountering, to help them work through ethical complexity that comes with making decisions about treatment and who they should prioritise, how to deal with that many people in their waiting room when they only have so many hours, and many other issues that Ziwan and Andrew have talked about. So giving them some time to work through the concerns that they have, the emotions that they're feeling, and then identifying strategies to address them. And they may be strategies that they can do on a personal level, but more likely it's going to be strategies that clinicians can do collaboratively and amongst, the many disciplines involved in cancer care. So I think that's probably my main message, is that clinicians need structures, systems in the workplace that prioritise their well-being and their capacity to care for patients. And that's what they're after. And it needs to be recognised at the health leaders level. It needs to be built into the system. It needs to be given priority in the same way that priority and decisions were made about letting visitors in. The same level of attention and detail needs to go into what policy and strategy do we need to support clinicians to do their job. And it really needs to be elevated to that level.
This conversation is a vital first step because we're taking the time to listen to those who are affected. Today we have heard from oncologists, nurses, and the patient's experience through family members. Clearly there needs to be a lot more discussion about how Victoria will deal with the surge in cancer patients, and although I don't like to say this, potentially a parallel wave of COVID. Today's discussion may have caused stress for some. If you or anyone you know needs help, there are people out there to talk to. The numbers are on the screen. We turn now to our next story. According to the latest data from the Victorian Cancer Registry, For people with pancreatic cancer living in the southern Melbourne region, the 5-year survival rate is only 10%. That's pretty grim. Up until now, there has been no locally accepted common definition of borderline resectable disease for pancreatic cancer in Victoria. To put this in lay terms, some tumours are really tricky to remove, and it's largely up to the surgeon to decide whether or not to proceed. Some will, some won't. The lack of documented and agreed common criteria to define resectability is a barrier to determining appropriate treatment for pancreatic patients. But there has been a new development in the way surgeons define borderline resectable disease, which may open up further possible treatment options for patients. Two of the lead clinicians in this exciting new project are Dr. Charles Pilgrim and Associate Professor Samantha Ellis. Dr. Pilgrim, you're a hepatobiliary surgeon and one of the leads on this statewide pancreatic cancer project. Before we get into the details of the project, can you tell us what exactly is the function of the pancreas and what are the usual symptoms of pancreatic cancer?
The pancreas is one of the important digestive organs. It sits deeply situated in the abdomen. Its two primary functions are in the production of insulin and some of the hormones that go into glucose metabolism, and it also produces a number of the digestive enzymes which we use to break down our food. Pancreas cancer most commonly presents as the patient going yellow and jaundiced, and following that obvious change in colour, patients present to their GP and liver tests ordered as a blood draw show an obstruction to the flow of one of the digestive enzymes. Following that, patients undergo scanning, often ultrasound and ultimately CT scanning, which shows the problem being a blockage in the pancreas.
And how serious is the disease in Australia today?
Unfortunately, 2/3 of patients who present, or when they present with pancreas cancer, it's already spread to other organs such as the liver or the lungs, and in those patients there's no surgery that we can offer. And in the third of patients in who we can't see any cancer that's spread elsewhere, 1/3 of them will be too old or sick to contemplate having surgery. A further third will have local progression of the disease, which meaning surgery is not an option, and therefore only 1/3 of 1/3, or about 10% of patients, can ever be considered for surgery. So it's fair to say it remains a formidable disease. And you've already said the 5-year survival is not great, but is improving, and there is some hope for the future.
This project, led by the Southern Melbourne Integrated Cancer Service and the North Eastern Integrated Cancer Service, as I understand it, covers the radiological component of the diagnosis. How did the project come about?
Well, I've said that 1/3 of patients don't have obvious spread to other organs, but within that group, who we say are non-metastatic, there's still a wide spectrum of how locally advanced the disease is. Some patients, the tumour is clearly resectable, and other patients it's clearly locally advanced, but there is a borderline group in the middle. And what constitutes borderline resectable pancreas cancer is an arguable point, and there are many different definitions and descriptions of what could be considered borderline.
What will be the ongoing benefits of this brand new tool?
Well, if we can agree on what is truly borderline resectable, then we can all speak the same language and therefore be able to compare results from all of the different centres in Victoria that perform surgery on pancreas cancers, and really therefore nut out what variations exist across the state. And if we can eliminate those variations, we expect to be able to increase the standard overall and improve patients' outcomes.
You use the word language. Does that mean you're doing something about the language to describe this disease?
Well, the project is to agree on a universal language and use of words to describe whether a cancer that's in the pancreas is in one of those three categories. Is it resectable, or is it locally advanced, or is it in that middle borderline resectable group? And specifically, we define that by its involvement or otherwise with the various arteries and veins that are in the area. So it's not really inventing words, it's just agreeing on using the same set of words and the same categorisation so that we can standardise care across the state. The 2017 Pancreas Cancer Summit that the Department of Health convened allowed us to identify that group of patients as being an area of deficiency and not being able to really identify who was locally advanced and who was resectable. And that was really what stimulated the need to agree on a statewide definition.
This project will be piloted across 2 locations, the Alfred and the Austin hospitals. Associate Professor Alice, you're a senior radiologist and the principal investigator for this project at the Alfred site, and you have been an active member of the project working committee. What is it about this project that really excites you?
Pancreatic cancer is now the 3rd leading cause of cancer-related death in the USA, and only about 15% of patients, when they present to their clinician, are actually deemed resectable. So this project is exciting because it's actually got together a large group of doctors specialised in the management of pancreatic cancer and trying to work out a better way to triage these patients down various treatment pathways. We now found with better chemotherapy agents available, better and more aggressive surgical techniques, there's now a small subgroup of patients, another 15% or so, that now fall into a borderline category for surgical resection. And we need to find that group of patients so that we've got better treatment options and better triaging of patients. So we get together a group of specialists, we work out those definitions, decide that we're all talking the same language and using the same terminology, and devising then a synoptic report or a template report so that we can then triage those patients better and offer better treatment options and outcomes for patients.
And what has been developed through this project that's a first for Australia?
So we've developed a synoptic report. What that is a fixed template report that has multiple categories that have to be filled in by the radiologist at the time of reporting the scan. By filling in all of those categories, and at the bottom you come up then with a conclusion as to the resectability status of the patient. And this is really what the surgeon wants to know. And by getting a group of specialists together, we've worked out what is important for the radiologist, what's important for the surgeon in terms of determining resectability, and also utilising the medical oncologists' specialist capabilities as well to work out this report. And in that report, all of the information is contained to then end up with a conclusion on the resectability status of that patient, and then that patient can be triaged down the appropriate treatment pathways by the surgeon. So this is an example of the radiology synoptic report. This is one of the first cases we actually placed on the database recently. And I'll just run through the categories, which are really quite straightforward. And you can see the first category is really just the basic details of the patient and of the actual scan itself as well. You'll note here that it says that there are unequivocal distal metastases. If you do notice metastases up front, liver, lung, for example, if you put yes there, it automatically takes you to the bottom of the template report because they're automatically deemed metastatic and unresectable, so you don't have to fill in all of the other subcategories. Failing that, like in this case where we've got a no, then we have to obviously importantly state whether it actually is a dedicated pancreatic cancer protocol CT. If not, we have to recommend the patient has an appropriate CT before we actually go any further with the filling in of the report. Next group is the mass characteristics, which are fairly straightforward. We move down to the arterial evaluation, and you can see here with the details regarding the supramesenteric artery, celiac axis and common hepatic artery, and you get some options with the drop down. For instance, is there less or greater than 180 degree arterial involvement? Importantly, arterial variance. This is very important for the surgeon, of course, when he goes in, if he's considering a resection, as to whether he needs to be aware of whether there is an anatomical variant. Venous evaluation is quite detailed. For example, if you take a look at the supramesenteric vein, whether it's involved, narrowed, and you'll see down here with the drop down that's either absent, present, you just describe whether it's unilateral or bilateral narrowing. Moving further down, additional findings. If there are some things that are a little equivocal, for instance, there's an adrenal lesion that you might think warrants further investigation, then you note it down in this sort of additional findings box. And then we come up to the resectability status. So then this is up to you to decide what is the resectability status of the patient. Is it resectable, borderline from the venous standpoint, borderline from the arterial aspect, unresectable or metastatic? This is the inbuilt logic, which is actually really quite interesting, and you can see it actually derives its own conclusion, which actually does concur with my conclusion above. At the moment we're not utilising that, and that will hopefully be something that will come to the fore later on, but we've just got that going in the background. If you're unsure, once you've ticked all the boxes in the above report, what category that patient falls under, then we've listed here very nice and succinctly in a box format what are the resectability status, and that's according to the international guidelines, and there's actually a reference to that below as well if you want to read that. And then right down the bottom, this is now filled in prior to the MDT, this template, and then we bring it along to the MDT, and after the discussion, if there are any changes made, differences in opinion, for instance, as to what the veins, the venous involvement, then we note that into that little box at the bottom, and then the whole thing then can get uploaded to the patient's clinical record. The long lasting is obviously very patient focused, and I believe now this small but very important subgroup of patients with borderline resectable cancer will hopefully be triaged appropriately, received chemotherapy, be re-imaged, and then hopefully become surgical candidates. So we're expanding that group of patients with now hopefully we'll have surgical options available to them, and therefore have better patient care and longer term outcomes.
Sounds like a fantastic tool.
It is going to be a fantastic tool.
Well, I hope you've enjoyed today's presentation. If you would like further information on any of the topics discussed today, here are the contact details for the Smics team. Thanks for joining us. Take care. Goodbye.